My name is Arti Thangudu, and I am an endocrinologist, aka diabetes specialist. And I have 3 goals for you guys for this talk. I want you guys to understand 1, why diabetes care sucks in America. 2, how this affects people, individuals, businesses, communities. And 3, how we can do better. So let's start with the problem. Well, this is what care looks like, care. So the problem, why diabetes care sucks in the US? Diabetes is so common that we as a society and healthcare community have forgotten that it is a highly complex, life-threatening disease. It has been brushed aside as prevention is not profitable. This has created an overall acceptance of diabetes. People think they have a touch of sugar until that touch of sugar becomes a touch of a heart attack, and then our reactive healthcare system finally starts to take our patients seriously. For most diseases, when in general medicine, if it's not getting better, we consult a specialist. We go to the expert. Let's say you have an ear infection. It's not getting better with your typical antibiotics. The primary care doctor will refer you to an ENT. You go see the ENT in a timely fashion. They fix it, and that's what it's like. But when it comes to diabetes, many patients are out of control for decades, 20, 30, 40 years, wrought with complications of diabetes, eye disease, kidney disease, heart attack, stroke, dialysis, and still have never seen a specialist, an endocrinologist. They have amputations. They've never seen an endocrinologist. The truth is 85% of people living with diabetes will never see an endocrinologist in the US. This is despite tons of data demonstrating improved outcomes when patients are seen by endocrinology. And so why is this? Why is it so different for diabetes? Well, sadly, access to great endocrinology is absent. 75% of US counties do not have a single endocrinologist. Endocrinology clinics have an average wait list or wait time of 3 to 6 months to get in. And oftentimes, to even get in, you have to meet stringent referral criteria. So we have a wonderful client in Lockhart, Texas with Greg and Lexi over there. And when we started rolling out this client, I did what I like to call reconnaissance work. So just trying to see what the lay of the land for patients looking for endocrinology looks like in that community. So I found the nearest endocrinology clinic that was near Austin, about 45 minutes from Lockhart. So far, but not horrible. And I thought, okay, well, what do they really need? So what did I do? I called the clinic, pretending to be a diabetes patient, a patient newly diagnosed with diabetes. And I asked, I was recently diagnosed with diabetes. Can I make an appointment? Seems like a simple, straightforward question in the appropriate place. And the receptionist said, well, no. And I was a bit taken aback. And I said, okay, well, why not? And they said, well, have you seen your PCP? And I said, no, but I am going to be paid with cash. So I don't have a referral need for my insurance to cover this. And the receptionist said, well, that doesn't matter to us. You still need to have a referral from your PCP. And I said, okay, well, after I get that referral from the PCP, what happens after that? And they said, well, we as a clinic will review that referral, see if we deem it as appropriate, that you need us bad enough. And then if we do say yes, then we will allow you to make an appointment. And I said, okay, still taken aback. And this was after waiting on hold for 30 minutes. This is the answer that I get. And she said, well, yes, you can make an appointment at that time. And I said, okay, so if I were to make an appointment today, when would that appointment actually be? And she said, it would be in 5 months. I wasn't even a real patient, and I felt disempowered. Can you imagine what it would be like for a real patient in that scenario? Diabetes is a serious condition, and patients are not getting the care that they need. So even when patients make it to an endocrinology clinic, oftentimes they're seen by a mid-level provider like a nurse practitioner or PA. And there's nothing intrinsically wrong with nurse practitioners or PAs. I don't have a problem with them. But if a PCP is sending their patient to an expert and that person is seeing an individual for care that has less expertise than the PCP, why would the PCP send the patient to the expert? It doesn't make good sense. So PCPs have given up on referring to endocrinology and are doing the best that they can for their patients with the resources that they have available in their clinics. So why is access so poor? Well, there are only approximately 5,000 endocrinologists in the US. So to give you some perspective, cardiology, there's 25,000 cardiologists. That's why if you want to make an appointment with a cardiologist, you probably can, even if it's for the sake of prevention. And there are 37 million, actually more than that now, people living with diabetes. And diabetes is not the only condition that endocrinologists treat. Whereas there are 30 million people with heart disease, all of heart disease. So the numbers people can't get into endocrinology. Endocrinologists are retiring faster than we are minting new fellows. And why is this? Well, sadly, it comes down to dollars. Endocrinology is the lowest paying medical specialty that we have out there, despite being in highest demand. In this crazy healthcare system, the laws of supply and demand don't apply. And while it stinks that it comes down to money, it doesn't make economic sense for physicians who go out there to train longer to get paid less than they would as a hospitalist or a primary care doctor. So access is a major reason that diabetes care stinks. But let's say a patient has broken through all those barriers. They're able to see the endocrinologist. They run through all of those barricades, and they make it into their endocrinology clinic to see their specialist, and they actually get to see the specialist. Well, like I said, diabetes is a very low, or endocrinology is a very low reimbursed specialty. So what happens in a very low reimbursed specialty? Doctors have to see a ton of patients, right? And so diabetes is a complex disease, but endocrinologists have to see so many patients that time isn't there. And time is a huge barrier. Diabetes is complex. Patients need education. They need support. They need access between visits. And care is better when physicians have time to think, build relationships, to coordinate care, especially in complicated patients. So endocrinologists practicing in the traditional insurance model do better. Outcomes say that they do better than perhaps primary care, but they still don't have time to provide care to the best of their capabilities. And with the lack of time comes a lack of support. Diabetes is complicated, it's confusing. Patients are with their blood sugar every single second of every single minute of every single day. They have complex medication regimens, sometimes on multiple daily injections. Sometimes they have devices, insulin pumps, continuous glucose monitors that need assistance. They need to be interpreted. And patients are asked to think about their disease all the time. And when they don't, we blame them, but they're asked to do this with absolutely no guidance. And I don't know if any of you guys have ever tried to get in touch with an endocrinology clinic in the traditional model, but I have, because when I was practicing in that way, I had several patients telling me that they would call my clinic and they would never get their call answered. And in the beginning, I didn't believe them. But then when 10, 15, every single patient is coming in with the same complaint and you're spending, the 10 minutes that you have with the patient apologizing for this, you start to wonder. And so I sat in my office and I called my clinic while I was charting, and I could not get through. I literally sat on hold for 2 hours and no one answered a call coming from the clinic to the clinic. It was absolutely ridiculous. When I was in the traditional insurance model of endocrinology, I had, patients can communicate with their doctors through portals, right? And so I received portal messages that my patients had sent me in December, the following April. At that point, it's irrelevant. The patient is dead, right? Like, it is ridiculous. Or they've gone somewhere else, we hope, if they have somewhere better to go. So I reject this as care. This is not care. PCPs are working hard for all of our patients with diabetes, and it is our responsibility as endocrinologists to support them in caring for patients living with diabetes and hormonal conditions. That's our responsibility. But this isn't what is happening, and usual care for diabetes in traditional American healthcare makes patients sicker. And there's data to support that. It's not just me saying it, but patients get sicker with this traditional delivery of care. So how does this affect our people, our communities, our employers, our businesses, our workforce? Well, diabetes is the costliest chronic disease our nation faces. Dialysis is expensive. Cabbages are expensive. Amputations, expensive. Hospitalizations, these are very, very expensive complications of diabetes that are preventable with good care. And employers and patients are footing the bill for all of those complications and hospitalizations. They're footing the financial burden and also the emotional burden, which is huge with diabetes, and it cannot be ignored, and it should not be ignored. People with diabetes have more medical expenses. They take more time off work. They have decreased productivity when they're working when they're ill. And diabetes rates are growing. It's not going anywhere, folks. 30% of people in the U.S. have prediabetes, and in some areas of the U.S., especially in South Texas where we do a lot of work, some areas have diabetes rates of 25%. That's 1 in 4 people with diabetes. Diabetes is a major problem for all of us. Yet, I remain hopeful because I think there are some ways and some means to make this better, at least for people who are interested in doing so. And, I've talked about how diabetes is complex. And another thing that I think is important is, as a community, as a culture, as a healthcare system, for some reason, we blame patients for their diabetes. If they would just eat better, if they would just take their medications, if they weren't so lazy. Diabetes is not the patient's fault. Nobody wants to be sick. And I'll tell you how I know that it's not the patient's fault. 5 years ago, I was asked to take on my first employer client, a self-funded employer. At that time, I was super green, pretty new out of training, and these patients were failing primary care. And I thought, what am I going to do here? Like, these patients have failed primary care. What can I do? I had total imposter syndrome, but this group, for some reason, really believed that I had potential. So I ran with it. And that question of what can I do was answered within 3 months. The clinic added my expertise as an endocrinologist to a primary care clinic that valued time, access, and supported patients. I was afforded an hour to establish care with patients, to counsel them on lifestyle, to engage them, to empower them, and to teach them about their physiology. And I was afforded sufficient time for follow-ups. The clinic staff was great. They responded promptly to patients' concerns, and they looped me in when necessary, and I responded when they did so. We lifted that expertise, time, and access barrier, and voila, it worked. And it worked better than I could have ever imagined. So by giving these patients expertise, time, access, support, these patients on average reduce their A1C by more than 2%. So that's like 8 to 6, 9 to 7. We're taking patients who were high risk for complications to almost eliminating that risk. patients who started very poorly controlled, the patients that the system had completely given up on, called lazy, called incurable, high risk, nothing we can do about, with A1Cs, starting A1Cs with me above 9, they had a more than 3% A1C reduction. So 9 to 6. That's taking a high risk patient to a reasonably low risk patient for complications, hospitalizations. These patients lost weight. 85% of the patients lost weight. They stayed out of the hospital. None of them were hospitalized in several years for diabetes-related complications. They changed their exercise and eating habits, some of them tremendously, some of them a little bit. But as we know, even small changes can make a big impact. They were healthier, happier, engaged, empowered. And then in 2020, everybody knows the world changed. COVID came along, and we went from being an in-person clinic to providing care over telemedicine. And diabetes is one of these fields where there's a lot of technology, where we can do a lot of remote monitoring on patients. And from a technology standpoint, we were ready for this, actually. And the patients wanted it. Everybody was scared. We were scared. These patients were high risk for if they did get sick. One, none of our patients died from COVID, and they all had diabetes, which was amazing in itself. And we had sustained outcomes. And now, since there's been quite a bit of data demonstrating sustained or actually improved outcomes in patients living with diabetes getting care via telemedicine, along with decreased cost and increased access. And we also had high patient satisfaction. And I want to tell you about this population. This was a population of older adults. They were retirees, okay? And they had high satisfaction with telemedicine. Almost 100%, actually 100% satisfaction. One or two patients said they would rather come in, but telemedicine worked just fine for them. So when we saw that these patients were satisfied and doing great, this opened up a huge opportunity for us. Because like I said, 75% of US counties don't have an endocrinologist. So with telemedicine, we have a huge opportunity to lift that access barrier and to create access for busy working people. I'm a mom, I have a job, I have a household to run. If I can get a telemedicine appointment and I don't have to drive across town, park, wait, all of those things, that is way better for me. And that's true for a lot of people who are working, and also for employers whose employees would otherwise have to take more time off work, especially in remote areas. We have a client in Del Rio where patients would have to take 1 or 2 days off work to travel to San Antonio to see the endocrinologist. And not just them, but also their spouse, because most patients aren't wanting to make that trip alone. And so now we have been able to access patients in those 75% of counties without a local endocrinologist. And so in the past year, we've grown our team and added several employers in Texas and Oklahoma to our group who we care for via telemedicine with sustained results. And simply by doing the same thing, providing expertise, time, and access. We are extremely grateful for this work that enables patients to receive great care, that makes them better, to provide a service that benefits employers by, one, helping with employer retention by providing a service that their employees love, but more importantly, for their bottom line, keeping patients out of the hospital. Those hospital claims, we have looked at them, they are insanely high, and they are killing the employer's bottom line. And the triple whammy, the third wonderful thing that we love is this enables our clinicians to deliver the care that they want to, that they went into endocrinology for, and to have the relationships with the patients that truly are rewarding for both the patient and the clinician. So we feel like this is a triple win. So we have a brand new website. It's heyhealthy.com. that we have created a new brand for our employers. So please check it out. We have some wonderful brokers featured on there. We have our patient testimonials as well, and just a lot more detail on what we do. And you can stay here and chat and connect to learn more. I do have a handout for you guys to take with you as well, with more information, a QR code that will lead you to our contact box if you want to contact us in the future. And I'm also here for questions. Does anybody have any questions? Yes, sir. Yeah, I think that is a really important point. And our goal is to be a consultant. And I think we need to think about this in a collaborative way. My goal for a direct primary care patient is not to steal their patient. It's to optimize their patient and educate the patient and also the PCP to get them back to their primary care. Because honestly, nobody wants to see 5 different doctors, right? And so if we can get the patient optimized in a 3 to 6 month period and then send them back to their DPC, I think that's a great outcome. And as a specialist, we don't really want to be doing primary care, honestly. There's enough diabetes to go around, and that's what we love to do. And so I think we should see it as a collaborative space. And you guys know me, that's my cell number. If you're a primary care doc and you need a curbside consult, I'm your girl. I'm happy to help, even if the patient isn't sent to me, because there's just such a need for endocrinology and a dearth of providers, and patients aren't getting the care that they need because they don't have access. So seriously, take my cell phone down, text me if you need my help on a patient, even if it's not diabetes, thyroid disease, anything. I'll tell you a story about that, actually. So we used to live in San Antonio. My husband's an ICU physician, and there's no inpatient endocrinologist in San Antonio. And there were patients dying on the cardiology service from thyrotoxicosis, hyperthyroidism, thyroid storm. People should not die from this, okay, with their thyroid inside their body. We know this as endocrinologists. We treated a lot of patients in fellowship with this. In 1 year, 5 patients died from thyrotoxicosis. And I had my second child, and I was on maternity leave, and one of our good friends, who was my husband's colleague, had one of these patients. He was managing him from the intensive care side, and he said, "Can you help me with this patient?" And like I said, my son was like 3 weeks old. So I was like, okay, yes, but let me come to the hospital and see the patient. And diagnose the patient within minutes of amiodarone-induced thyrotoxicosis. Basically, talked to ENT, teed him up for thyroidectomy that week, and he was supposed to get his thyroid out. He was going to live, and he'd been in the hospital for 45 days with this condition. Ultimately, on the morning of surgery, the patient perfed his bowel, completely unrelated to the thyroid, and died from that. But had we seen him a couple weeks earlier and did the same thing, he would have walked out of the hospital. I'm sure of it, And so the lack of access to endocrinology is a matter of life and death for some people. And I'm here. Seriously, call me. I don't want people dying in things that we can prevent. Yes. Yes.
There's challenges when I'm doing virtual care. For an endocrinology practice, what do you find are the trickiest or the most challenging things when you're doing virtual care?
So some patients do not understand how to use technology. And so virtual care, I do pretty much all telemedicine, and I will tell you, it is not for every patient. And so for us, we have to identify those patients, and we discuss as a team, like, if patients are having challenges, we discuss, hey, is this patient a good candidate for virtual care because some patients, they have poor dexterity and they have an insulin pump, and those patients, if they can't adjust their own insulin pump or they can't figure out how to adjust their own insulin pump, well, they need a in-person CDE helping them do those things. So endocrinology is a very cerebral specialty. We do a lot of lab analysis and like blood work analysis and talking to a patient. That's the majority of what we do. But we have to be able to draw the line of, hey, this isn't a good candidate. Or if the patient is saying, I have a foot infection or there's something going on in my feet and we aren't able to actually inspect the foot, like we'll send them to somebody who can see them in person. And so I think the collaboration between a local direct primary care, and an endocrinologist is really the optimal situation for a patient. Yes, sir.
Arti, thank you so much for your passion and what you do. Have you thought about working with a company? For example, I'm a Northwind. We have a clinical diabetes solution for employers. We carve out the diabetes spend. Have you thought about partnering with a company like ours or with a company itself to carve out their diabetes population completely, and then you work directly with them? I mean, maybe it's the next evolution, maybe, but I love what you're doing.
Yeah, absolutely. Like we really want to increase access, like I talked about, and so any way that we can do that, I'm game for. And I've definitely thought about, can we collaborate with advanced primary care clinics or other providers or groups that we can just collaborate with to advance that access for sure. But yeah, let's talk after.
Well, the medications are also hard to source, and yet, if you can remove that barrier for patients, if they're teaching them their medications that they can afford, that's a huge barrier.
Yeah, and actually Greg and I were just talking about that yesterday. So we're hoping to roll something like that out in the next few months. Yes, ma'am.
And 9, and I can confirm everything you're saying. She's had a terrible time. She's an attorney in Denver, currently doesn't have an endocrinologist, but a direct primary care doctor who I hooked her up with once I learned about this has saved her life. So my question is, do you take clients telemedicine like from Denver?
So we have to be licensed in the state where we take care of patients, but I was talking to Kempton Group and they did suggest that we get licensed in Colorado. So that might be, I think Kansas is on our list, Colorado, and we'll go wherever their patients are.
A virtual relationship would change her world because she has to take off work and it's just been a whole thing. So I'll be in contact with you.
Perfect. Yeah. Take down literally this is my actual cell phone number. So text me anytime.
Okay. Sounds good.
And we'll get her taken care of.
I just want to thank you for everything you're doing. I know a lot of people aren't well educated on how to take care of themselves when it comes to their diabetes. And my brother actually passed away at 30 from not being able to manage it and not knowing the importance of it. So I admire what you're doing and think it's absolutely spectacular.
Oh, I'm sorry to hear that, but thank you so much for the kind words.
Can you work with people across the country?
So like I said, we're licensed currently in Texas and Oklahoma.
Okay.
But we are growing. We're adding to that as the year goes on. I have 2 other endocrinologists that are on my team now, and we will go where the patients are. So if there's a need somewhere else, let us know, and we'll work on it. We're part of that interlicensing compact, so it's pretty easy for us to get licensed in states that are on that compact, and a lot of states are on that compact.
To get away without kind of providing an input on GLP-1 medications and the access of them right now or lack thereof. Would appreciate any insight you have on that.
This could be a hair talk on itself, but so GLP-1 receptor agonists are I'm sure everybody knows what they are, but maybe not. So there are new-ish diabetes medications. They're very popular because they've been popularized via social media, but we've been using them in the diabetes space for over a decade. They are not new medications. And patients tend to do very well on them overall if they are screened well for appropriateness, if they're medications are titrated appropriately, and if they are monitored and supported in their use of these medications, as well as lifestyle that can go along with it. So they're very powerful medications, very popular. Now we're hearing a lot of adverse effects, I think, because of inappropriate prescribing habits and inappropriate use of the medications, because everybody wants to lose weight, even if they don't have a metabolic reason to do so. So if the risk outweighs the benefit, well, we're going to see a lot of adverse effects. So access, this is the bane of my existence. The number of times I have, while I've been here at the conference, written Mounjaro at a different dose to a different pharmacy, calling my Lilly rep, trying to get the medication for patients has been a bear, to say the least. It's probably endocrinologists are spending more time doing that than actually seeing patients at this point. They're very popular. Lilly last week was trying to push out 4 million doses per week to keep up with the demand. So it is insane out there, and I really feel for patients who are trying to get these medications. Patients do extraordinarily well when they're treated appropriately with these medications. There are compounding pharmacies that are capitalizing on this, which I am terrified of, because there are some situations where compounding makes sense, right? But in this situation, we don't have any data on the compounded medications, and they are being compounded in very strange Breaking Bad-like pharmacy situations, people's garages, basements, and then being sold to patients. And if that doesn't scare you, I don't know what to say. But there are unsanitary conditions, questionable purity. I just don't really know how somebody could feel safe taking that. I know people are desperate, but I don't think that's the answer at this point. So I would highly recommend against those compounded versions of these medications. And we just need to get people. I don't know how to get ahead of the social media on this. I mean, the Kardashians and Elon Musk have a lot more followers than I do on Instagram. So, but I think we all have a part to play in this. Now, you guys know compounding isn't great. These medications need to be used appropriately, because the adverse effects are significant. Like, people are hospitalized for bowel obstruction if they're inappropriately using these medications or up titrating too much. They're on a real gastroparesis, like real long-term problems that could be potentially fatal. Not to scare people. I use these medications all the time. I love them in the right patients. But I don't think they're a cure-all for everybody, and they certainly have real risks that we need to be discussing with the patients. I know that was a very roundabout answer, but I hope it answered some of your questions. Thank you, guys, and I'll be here, so if you have any more questions, please don't hesitate to reach out.